along. I think it's testament to the impact of cancer on all of us, on the Western world in general at the moment, in that you'd rather be here listening to a crusty old academic talk than watching Wimbledon, for example. Or even, we'll try and finish so you can get home to watch Boris Johnson on the television. As Julian says, cancer is going to impact on everybody. 1 in 2 of us will have a direct impact of cancer on our lives. 1 in 3 of us will probably get carried off by it. There's a lot of work going on in the field of cancer therapy, in particular cancer immunotherapy, and I'm an immunologist, I'm not a clinician. But I think we hear so many reports in the press, on our Twitter feeds, of how the next miracle cure for cancer is coming along, and they always disappoint. There's never a great deal of follow-through from that. But I think in science at the moment, we don't have that many eureka moments. I think what we have are a lot of very dedicated people working very hard to incrementally improve our knowledge of a particular field. And I think the field of immunotherapy is perfect for that as an example, because lots of people work in the field, and we do make a move in terms of improving our cancer therapies. So what is cancer? This is a cell undergoing division. And what we find out with cancer is that cancer is basically a cell that's gone wrong. It's a cell that can no longer control its own division. It divides and it divides and it divides. And normally a cell has a limited lifespan. It knows when to die. And another problem with a cancer cell is it's unable to die. And we know from a lot of pathology work that cancers tend to kill people because they block stuff. They just get big. They block your blood vessels, they encroach onto tissues, they produce things which are detrimental to the health of the individual. So, how do we deal with cancer? 3 treatments, usually at the moment. We have surgery, which is our first one. Now, surgery is great. It cuts out a huge swathe of tumor. It allows us to remove the bulk of the disease. But the problem with cancer is that it metastasizes. So little bits of tumor break off and wander around the body through the blood system, through the lymphatics, and set up home somewhere else in the body. So we can get rid of the primary site of the tumor. However, dealing with the metastatic lesions is a lot more difficult. The second way that people have treated cancer is to use radiotherapy. This is using high-energy ionizing radiation to damage the DNA of a cancer cell to render it incapable of dividing. Now, the problem with that is that it's not specific to cancer. Any rapidly dividing cell would also be affected by radiation. And we know from the side effects of radiotherapy, such as the gastrointestinal problems and the hair loss, that rapidly dividing cells are simply not immune from this treatment. Thirdly, there's chemotherapy. Again, chemotherapy is a blunt tool. It's something which is given systemically by and large, and again, it tends to target rapidly dividing cells by intercalating in their DNA. And again, there are lots of unpleasant side effects. Now, more recently, these particular therapies have got better. So radiotherapy can now be used from a number of different beams of radiation being shot into the individual. Low-dose radiation, which when they intersect at the site of the tumor, they can cause damage and therefore remove the tumor that way. Similarly, with a lot of chemotherapy reagents, now we can target them specifically to particular sites. So things are moving on in this field. But I'm going to talk to you about immunology, which is by far and away the most interesting thing about science at the moment. Immunology is your body's ability to defend itself against infection. So it gives you protection against bacteria, against viruses, against fungi. Every time that you cut yourself and you get an inflammation around that tissue, that's the immune system kicking in and protecting you. The interesting thing about the immune system is now think it can protect us against cancer. Okay. Now, this is not a new thing. So this chap is Paul Ehrlich, and he was awarded the Nobel Prize in the early part of the 20th century for his work in medicine. And he framed the phrase, cancer will be quite common in long-lived organisms if not for the protective effects of immunology or immunity. So one of the things that we have to remember is despite the horror stories of childhood leukemias and lymphomas and those awful diseases, in the main, cancer is still a disease of an aging population. Another reason, or some secondary information that we've got about the role of the immune system in cancer, is that if you take out part of the immune system, if the immune system is compromised in some way, for example, by a disease such as HIV, human immunodeficiency virus, if we compromise the immune system, some very rare cancers such as Kaposi's sarcoma and some lymphomas can arise. So basically, if you take away the immune system, you develop cancers. We also know that if you take the tumor from an individual and you take it apart and you look at the cells that are infiltrating that tumor, in those patients whose tumors have got an infiltration of immune cells, they tend to do quite well in terms of their prognosis, rather than those that don't have an infiltration of immune cells. So we know the immune system can affect cancers. So why doesn't it protect us? So tumor cells divide very quickly. They also have a mutation rate which is very, very high, probably about 1,000 times greater than a normal cell. And this essentially means that when the immune system locks onto one of these tumor cells, it's mutating. And so essentially, the immune system is chasing a moving target and quite often can't catch up with it. We have had an area of immunology called immune surveillance, which has been coming to the fore just recently, where we're trying to find out how the immune system does monitor the individual for cancer. And this has been condensed down into 3 phases, which is elimination, equilibrium, and evasion. So this is quite a complicated slide, but what it's trying to do is give you an idea of what's going on normally. So if we have a normal tissue, which is this bit here, if that normal tissue gets subjected to some sort of cancer-inducing event, such as a carcinogen, radiation, viral infections, or chronic inflammation, a number of those cells can become cancerous, as indicated by this orangey-looking cell here. When this happens, the cells can throw out signals to say, look at me, there's something wrong with me, come along and kill me. And the immune system will then recognize those signals and get recruited, and this is a wide range of immune cells here, which can recognize these transformed cells, these cancerous cells, and can clear them, can kill them. And then you have essentially elimination of the disease. But because of this constant rate of mutation of a tumor cell, some of these cells will evade that initial onslaught of the immune system and will sit quietly in the tissue until perhaps another event, another mutation, which will then reawaken that and take this tumor cell from out of equilibrium with the immune system to the escape of the immune system. And this is where the trouble starts. So when the tumor is evading the immune system, it's capable of switching the immune system off. It's capable of producing signals which will tell these killer cells here, these cells which will kill the cell, it will tell them to stop and not to kill them. And that will come back to me a little bit later in the talk, will give us an idea of how some of these immune interventions can work. So how can we use our immune system? There are 2 ways we can deal with cancer using the immune system. We can boost the immune response to the cancer, or we can stop the cancer from blocking the immune response that's already there. So how can we use the immune system? Number 2 is that tumor cells, when they mutate, they produce quite unique molecules. So the immune system is designed and is educated so that it recognizes your body as being you, and it won't attack it, but it will attack something that it doesn't recognize. So if a tumor molecule, for example, is mutated, it means it's no longer the same as the self molecule. It's changed. And therefore the immune system can get a handle on it and attack it. Mutated molecules are different. And we can use this difference to create a vaccine. A vaccine much in the same way as you get against TB or smallpox. So I've only got a couple more slides to show you. The first one is one way in which we believe we can boost the immune response. And this is using a technique which was essentially invented by a guy called Ralph Steinman, who was awarded the Nobel Prize in Medicine in 2011. It's the second Nobel Prize so far. Ralph Steinman was working on a population of cells called the dendritic cell. Now, the dendritic cell is one of those prime movers of the immune system. It's often thought of as being perhaps the conductor of the immunological orchestra. It tells the immune system what to target, what to kill, what to do. We can make these dendritic cells in the lab. So what Ralph Steinman developed was a method of taking monocytes, which is one of the peripheral blood white cells, take those cells out, put them in culture in the lab, add to them a couple of magic potions, a couple of lymphokines, and we can generate a population of dendritic cells. We can then take those dendritic cells, we can load them with some of the tumor material, either from the patient that the individual that the vaccine has been made from, or from tumor cell lines that are available in the laboratory. Put them back into these DCs, put those DCs then back into the patient, and we should be able then to induce an immune response in the patient against the tumor. And by and large, it works. It works in about 15 to 20% of individuals it's tried with. It's very expensive. I mean, Gus was telling me it's about £150,000 per year for this sort of therapy. Far too expensive. And it takes a long time. So to generate these disease vaccines takes weeks, and sometimes the patients simply don't have weeks. But that is one way in which the immune system can be used to target cancer. The second one is the one that hopefully we'll hear a bit more about, which is stopping the block. So I talked about how the tumor can switch off the immune system. So last year, Jim Allison and Tasuku Honjo were awarded the Nobel Prize. It's the third Nobel Prize so far in this talk. And for the work that they did on something called checkpoints and checkpoint inhibition. So if you look at this figure here, this is a killer cell. This is a cell that can kill tumor. You recognize it. This is a tumor. The tumors can produce these molecules, in this case called PDL2, which interacts with a molecule on the CD8 killer T cell called PD1. When this interaction takes place, the tumor cell switches off the killer cell. Okay? If we interfere with this by blocking it, we can release the brake on these killer cells and let them kill the tumor. And this is what happens with an antibodies, which we can generate against these molecules, which I think Alberto is going to talk about in a little bit later. So, checkpoint inhibition is probably the way forward so far. It's certainly one of the best ways of treating cancer that we've got. And we've got a success rate of about 20-25% with this at the moment. And the expectation is we can go even further. So we can start to save people even more. It's also expensive, but not as expensive as dendritic cell vaccines. It's about 50 to 80,000 pounds per year. All the work that we do here is sponsored by charities. And these are the three charities that are sponsoring our work. We have the Institute for Cancer Vaccines and Immunotherapy, and we have people from there talking to us today. Public Health England have been instrumental in some of the work that we've been doing at Porton Down. And Cancer Research UK is also a big funder here in the UK, and we've just been awarded some money from Cancer Research UK to try and make it cheaper to treat people. So that's all I really want to say. That's an introduction to immunotherapy. I've taken my 15 minutes. So now I'm going to introduce you to the rest of the people who will talk today. We've got Alberto Fujiyama, who's a senior clinical lecturer here at St George's, who's running clinical trials here. And he's going to tell you a little bit about what's happening in the field of clinical trials. It's our great pleasure to introduce Mr. Donald Howie, who's a patient who's been treated on one of the clinical trials here by Gus Dalgleish and Alberto. So it's very, very kind of you to come along and talk to us. Marie Dimmond is from one of the cancer charities that supports us, one of the main cancer charities that supports us, and she's going to tell us a little bit about some of the problems of fundraising, or trials of fundraising. And then, as a star attraction, I suppose, Gus Dalgleish is going to talk to us about what he thinks is the future of immunotherapy and how it will move on in the next few years. Okay. And then finally, you're very welcome to stay. We'll have a Q&A session here amongst between ourselves, and then we can have a couple of demonstrations over the side there. There's some cancer cells if you're interested in looking at them, or some rather gruesome exhibits from the Pathology Museum. Okay, so that's all I wanted to say, and now I'm going to introduce Dr. Alberto Fujiyama to come and talk about his clinical trials. So thank you. Oh, do you want that?
Oh, yeah, thank you.
Yeah, that's a viewable thing.
Yeah. Thanks. So good evening. My name is Alberto Fujiyama. I'm a medical oncologist here at St. George's, focused on skin cancer, specifically melanoma. But I also work as a senior lecturer here in the university in the group of Professor Dalgleish. And I've been given the task this evening to talk to you about some of the clinical aspects of cancer immunotherapy. So immunotherapy, have you just heard, and in particular checkpoints blockade, which are the approved treatment for different solid tumors, are representing a major advance in cancer management. Specifically, this checkpoint blockade, they show to improve the outcome of patients with different solid tumors, both in terms of response rate, which means increasing the fraction of patients who are actually responding to cancer treatment, but also extending the survival of these patients. New treatments which are associated to novel immune-mediated toxicity, which is completely different compared to the toxicity that we are used to see with other classes of antineoplastic agents, and therefore require specialized management. You've just seen something very similar about checkpoints blockade, and these new immunotherapeutic agents, they basically blocked inhibitory signals between the tumor and a cell of the immune system, a killer cell, a T cell, or between two cells of the immune system at an early stage of immune response, so in the lymph glands. We have anti-CTLA-4 antibodies, which blocked the interaction between dendritic cells and T cells. We have one antibody approved, it's called ipilimumab, it's approved for melanoma as single agent, but also in combination with an anti-PD-1 antibody for both melanoma and kidney cancer. And then we have a few checkpoints blockade acting at the interface between T cells and cancer cells. We have anti-PD-L1 antibodies blocking this protein, which is usually expressed on cancer cells, and anti-PD-1 antibody, which are blocking PD-1 proteins expressed usually on T cells. And here are the numbers of anti-PD-1 and anti-PD-L1, and the only anti-CTLA-4 ipilimumab approved all over these years for different solid tumors. Ipilimumab was the first drug approved, was approved in 2011 for melanoma, but the first dose in patient was in 2000, so it took 11 years to get some data which convincingly shown that this molecule was extending the survival of the patients. And then afterwards we have a number of approvals, mainly of anti-PD-1 and anti-PD-L1 antibodies for a different spectrum of solid tumors. Here is missing one. We are always late now. This is a new antibody, a new anti-PD-1 antibody, which has been approved actually in UK last week. It's called cemiplimab. It's not on this slide. It's been approved for a specific type of skin cancer, metastatic squamous cell carcinoma of the skin. And as you can see in this picture, there is a broad activity. These checkpoints blockade have a broad activity, which depends really on the tumor type, but also within the same tumor type, it depends on the tumor characteristics. It works fairly well for melanoma and fairly well for kidney cancer. Here you see the response rate is about 30% of the patients with melanoma. They tend to respond to single agents checkpoints blockade. It works quite well for lung cancer, head and neck cancer. This 40% in colon cancer is biased because only a subset of colon cancer patients responded to checkpoints blockade, which is the 5% of all the colon cancer patients. So broad activity, which depends on tumor type, but if you see on average across all tumor types, the efficacy is about 20%. So big changes, major advance, but efficacy still in a limited fraction of patients. And these treatments have toxicity, as I said before. Which kind of toxicity? Usually the immune system is in a steady state, is in equilibrium. So is in a state where it prevents to attack its own cell, and it can eliminate infection or cancer cells, so to reject the invaders. Ideally, the goal of cancer immunotherapy is to bend the immune system curve, so eliminate the cancer with an immune response, but at the same time to try to avoid the immune system to attack its own cells, the cells of the body. What happens in reality is that when we activate the immune system, we induce some kind of attack of the cells of the immune system to the normal cells of the body, and therefore patients may develop autoimmunity. And these are the most common side effects, or the most targeted organs, that we can see in patients receiving checkpoints blockade. 3 most common side effects: skin rash, and usually pruritus, so itchy, is quite common in patients receiving checkpoints blockade. Second most common side effect are endocrine problems. Thyroid, 20% of the patients on immune checkpoints, they develop some kind of thyroid problem, mainly hypothyroidism, sometimes also hyperactivated thyroid. And about 20-25% of the patients, when given a single agent, develop gastrointestinal symptoms of an hepatitis. All these symptoms are immune-related, so we will have an autoimmune hepatitis, but also an autoimmune colitis, which is an inflammation of the bowel. We have learned how to manage these side effects. We have developed some algorithm to manage the side effects, algorithm based on the severity of these side effects. All the side effects are manageable. Sometimes they may be chronic. As I said before, across all tumor types, probably the response rate is about 20-25%. The majority of the patients do not respond to immunotherapy. Why is that? Many reasons. One of the reasons is that because the majority of the patients lack a pre-existing immunity. It means that in the tumor of patients, we don't have cells on the inflammation. So, and we know that patients who don't have inflammation in their tumor are less likely to respond to checkpoints blockade. What can we do? How can we increase the efficacy? So how can we switch these non-responders into potential responders? So how can we make a cold tumor, a tumor without inflammation, into a hot tumor, so a tumor with inflammation? Different strategies. To summarize, two main strategies. The first one is, of course, development of new agents acting on different levels on the immune response. And if you look here, we are already doing it very well. This is the pipeline of late phase oncology molecules in between 2007 and 2017. Targeted biologics include all the immunotherapeutic agents. We were representing only the 23% of all the anti-cancer treatments in clinical trials in 2007. Now they represent the 42%. I mean, 2017 was the 42% of all the molecules in phase 2 studies or further studies were represented by target biologics. So we were taking over this second class of molecule, also a very important revolution in cancer treatment, the so-called targeted small molecules. They don't target the immune system usually, they target abnormal protein of the cancer. So the difference between the two treatment strategies are, in this way, with the targeted small molecules, usually you target the cancer. With the biologics, with immunotherapy, you target the host. So you target the immune system of the host. These molecules, they work also fairly well, but they have a problem. They are time limited. Because as you heard before, the cancer tends to change, and therefore, like for the antibiotics, it may become resistant. So they are time limited. The immunotherapeutic agents, because the immune system has memory, if they work, they may work for a long period of time. I was used to say that there is a really huge ongoing research about immunotherapeutic agents. But it takes time. From patents of a molecule to the approval in patients, it takes usually 14 years. What can we do now? We can combine different agents together. We can combine immunotherapy, which you have seen, it doesn't impact much on the number of patients having more benefit, but it can extend the life expectancy of the patients, can be combined with a targeted treatment or a second immunotherapy in order to reach a higher number, to have a higher number of patients having long-term benefit. We can combine immunotherapy with these small molecules, targeted treatment. Which are the advantages? These small molecules attack the tumor, so not the host, attack the tumor. Usually they tend to work quite quickly, and because they kill the cancer cells, they increase the tumor antigenicity, which means they make the tumor more recognizable to the immune system. They can promote the migration of cells of the inflammation into the tumor, because we cause some very rapid tumor death. And we can also increase the expression of PD-L1 by the tumor. Of course, when we combine two drugs together, the possible disadvantage is that we increase toxicity in the patients. And this is how we would combine an immunotherapy with a targeted treatment. If a tumor is cold, so no presence of cells of the immune system, we can start a treatment which hopefully will induce some kind of response and induce some kind of inflammation in the tumor. This is the optimal window to start an immunotherapy, which hopefully will maintain the inflamed state and therefore long-term response. The other option is to combine two immunotherapeutic strategies. We have done it already. We have done it the first time with this study, published in 2015. In melanoma, we combined the anti-CTLA-4 antibody ipilimumab with the anti-PD-1 antibody, nivolumab. The response rate from single agent, which was around 35%, went up to 58%. So 58% of the patients with melanoma receiving this combination responded to treatment. But the problem was the toxicity, because 55% of the patients receiving the combination ended up in hospital to manage the toxicity. Which are the possible advantages of combining two immunotherapeutic agents? We can act on different levels and different stages of the immune system, and we can also hopefully drive a more specific immune response, therefore increasing the efficacy, reducing the toxicity. And here are examples of a possible combination that we can explore. At the moment, there are in clinical trials more than 300 combinations. St. George has been always very active in clinical research, and I'm proud to be the lead investigator on this clinical study, the MM101-015 study, which is also aiming to assess the safety and the efficacy of a new combination of nivolumab, which is an anti-PD-1 antibody, plus this drug called IMM101, which is a mycobacteria obuense heat-killed, which was already used previously in a phase 2 randomized clinical trial led by Professor Douglas in pancreatic cancer, which showed in this patient pancreatic cancer the combination of gemcitabine, which is a chemotherapy drug, plus IMM101, increased superiority in terms of overall survival and progression-free survival compared to patients who received the chemotherapy alone. So, of course, we are trying to assess this combination with another immunotherapy, nivolumab, in melanoma patients. Two different cohorts, patients who are treatment naive, so never received treatment before, but also a cohort of patients who have already been treated previously with some checkpoints blockade and they failed, with the aim of switching this non-responder into responders. And to this study, we have a research also attached specifically to identify some specific biomarkers, a research that I'm doing with Peter Smith, who may be in the audience, with the aim of identifying biomarkers for this patient in order to select patients that can respond to specific treatment. This is the way to go to the future, which will be personalized medicine. Thank you for your attention.
Okay, thank you very much.
Prof. Dalgleish, Dr. Fusey, Carol, Sheila, distinguished speakers, guests, ladies and gentlemen, good evening. Dr. Fusey asked me to share a few of my experiences about the trial and my experiences with melanoma. Indeed, I'm sure that all the patients here share similar experiences, and I'm happy to answer some questions afterwards, as long as they're fairly easy, please. Firstly, I believe that we should thank our loved ones who are probably with us in the audience today, our partners who have supported us through some darker days, and now continue by our sides as we travel on a journey to brighter, healthier lives. So can my fellow patients give our partners and our families, all our helpers, a smashing thank you applause. Thank you for your continued support of us. This evening I'd like to thank so many professionals who have helped me, and indeed all of us, caring and treating us with our melanoma. Sadly, time does not allow us to expand very long, thanking those caring individuals this evening. save to say our sincere thanks to Carol, Sheila, and indeed all the team in Haematology Oncology Outpatients Clinic, known to our professionals as HOOP. I think we can give HOOP a little round of applause. Carol and Sheila in our audience. I wish to share a lasting lifetime experience with you all this evening. It's a phone call you never want to miss, and I missed it. As usual, I arrived in clinic and was immediately seen by Prof. Dalgleish. Mr. Howie, did you receive my telephone call or voicemail? I apologise, Prof. Otherwise, I would have responded immediately. Prof checked my telephone number and all was correct. Prof was animated in his own clinic. Mr. Howie, we have the authorization. We have the funding. Mr. Howie, it's perfect timing for you. I'm putting you on a trial using a revolutionary combination of immunotherapy and a collaborative drug. Mr. Howie, it's called IMM 101. Mr. Howie, its success rate is massively high. It's zero, its side effects are virtually zero. Mr. Howie, you will start the treatment immediately. Yes, Prof. Ladies and gentlemen, to this day, I do not know how I missed that telephone call. Ladies and gentlemen, our Prof Dalgleish. Halfway. As instructed, I reported to Dr. Fusey. Dr. Fusey ensured that I met all the medical criteria for the IMM 101 trial, although I had a wobbly start. But with the help of Dr. Fusey and his research nurse Joan and our other professionals here this evening, I was enrolled in the new dawn of immunotherapy treatments, IMM 101. Thanks to Dr. Fusey and IMM 101, my results were instantly making progress. My very first CT scan showed immediate reduction in the size of my tumours, just as Dr. Fusey said they would on day one. Where's Dr. Fusey? Ladies and gentlemen, Dr. Fusey, where are you, sir? Thank you, Dr. Fusey. Ladies and gentlemen, I'm proud and privileged to share some of my experiences with each of you on the IMM 101 trial. Before being placed on the trial, I was living a 3-monthly period of hope, just hoping that good news was in the next visit to clinic. Sometimes, yes. Sadly, that was not always the case. Now, with IMM 101 intelligently curing me of this disease, I confidently look forward to my clinical consultations with Dr. Fusey. Ladies and gentlemen, I'm getting my life back thanks to the successful IMM 101 trial. As stated, with immediate effect after the very first vaccine of IMM 101, my scans were looking very good. My tumours were decreasing. My subsequent scans continue to show fantastic progress. Being successfully treated by this intelligent vaccine was, of course, one of the best saving life experience one could ever want to receive. Indeed, I received it. Another part of my treatment is that of the zero side effects. Distinguished guests, I have never felt nauseous. I have never felt or been sick. It's non-invasive. I am certainly not in a hospital bed. My clinical appointments are easily managed. With IMM 101, I'm working and in full-time employment, and I would have hated an itchy skin. Thanks to the trial, I now find myself with a real sense of well-being. I now feel really very well and confident. Again, 0 side effects. All thanks to IMM 101 trial. In conclusion, Prof, Dr. Fusey, distinguished speakers, guests, I believe another driving force in my treatment is a certain knowledge that you are thrilled that this intelligent vaccine is very much smarter than cancer. In IMM 101, I have no fear of my adversary. In IMM, I am getting better. Ladies and gentlemen, well, fellow patients, we're all getting better. In certain knowledge, I know that our successful IMM 101 vaccine is killing my cancer. And I'm so utterly confident that in the future, I will be cured and free of melanoma. We all, fellow patients, will be free of melanoma. Ladies and gentlemen, thank you for allowing me to share some of my personal thoughts and experience with each of you. And again, my continued thanks for enrolling me on your life-saving, successful, our life-saving, successful IMM 101 trial. Ladies and gentlemen, thank you very much indeed. Thank you.
Thank you, sir. Now, our next speaker is the work. Is Marie Dimon, who's one of the preparation manager at the Institute for Cancer Vaccines and Immunotherapy.
First of all, I'd like to say, Mr. Howie, that was a great talk. Thank you. That was really brilliant to listen to. So my name's Marie Diamond. I am in charge of the fundraising for the charity which funds Professor Dalglish's research here at St George's. So I just want to tell you a little bit about the charity. Started in the year 2000 by a group of grateful patients of Professor Dalglish, a bit like Mr. Howie, I imagine, 20 years ago. So it's our 20th birthday next year. At the time, immunotherapy was overlooked by a lot of the major funders. And Professor Dalglish wanted to do some research in that area and was unable to get funding for it. So the charity was started by patients and their relatives who wanted to help him with the funding. And we're still going, nearly 20 years on. We were very unique then because nobody wanted to fund immunotherapy. We remain unique because our research is directly informed by what Professor Dalglish sees in his clinic. He then informs his research team to do projects which will help his patients directly. So that's a really unique approach, I think. The other thing to say about us is that we offer incredible value to our donors. So 84 pence in every pound goes directly to our research team. We have a few supporters, not a huge amount of supporters, but we have some excellent supporters. They're very high quality supporters, which is always good for a charity. They're very dedicated and they raise lots and lots of money for us. At the moment, we are raising funds because we're always raising funds. See a little girl doing a cake sale there. We want to expand our team at St George's to help build on our successes that have been ongoing for the past 20 years. We also want to run more clinical trials like the ones Dr. Fusey is running. And that's why we always need more money coming in. What we really need to do is raise our profile. People need to know there's an alternative to donating to very large charities who can afford all the television adverts and the publicity. We prefer to spend our money on the research, and the problem with that is people don't really know about us. And I know that Professor Dalglish has patients coming to him saying, "Oh, I ran a marathon for you." And he says, "Oh, did you?" And they haven't at all. They've run a marathon for another cancer charity that advertises on the telly. So that's kind of frustrating. So it would be really lovely to raise our profile, both locally and nationally. So if anybody wants to get involved in raising funds for us, we'd absolutely love to hear from you. My colleague is over there with lots of information, including a trial that we're hoping to fund, which helps people with women with ovarian cancer. So that's a really great project. The other thing I should mention that we do is we organise a symposium, which is every 2 years at the Royal Society, and we get experts from all over the world who talk about, advances, and everybody gets together and collaborates, and that's also really important. So that's it really, that's all I'm going to say, but if you would like more information, you can have a look at our website, you can give us a call, you can get information from over at the side, and we would absolutely love to hear from you. That's it, thank you.
Okay, thank you very much for coming to hear this work that we're doing in immunotherapy. I've been charged with talking about the future a little bit, but I'm just going to try and put it in context. It's late in the evening. I don't want to bore you with facts and figures, but just basically the context of what we're dealing with. And 2 words I put together, because we've heard of them tonight, is one is inflammation and cancer. There's a real paradox with inflammation. I'm going to show you data that, kind of surprisingly, our work has shown that if you've got a chronic inflammatory background, you don't respond to the treatment very well. And yet you'll hear inflammation used in another context, that you need the tumour to be inflamed. And it would appear to be this is a real paradox. If you're systemically inflamed, the tumour doesn't get infiltrated. If you're not systemically inflamed, the tumour is more like to be infiltrated. And I just want to explain that paradox because you're going to hear it. Now, I just want to introduce things historically in context, is that if you can see this here, this paper was published in the year 2000, nearly 20 years ago. The combined might of the NCI and the NIH basically had a war on cancer, and they spent billions. The basic science identified 6 parts of cancer that needed to be targeted, and they were targeted with drugs. And these are the famous drugs you've heard about today, things like Avastin, Herceptin, etc., etc. And in spite of the fact that immunotherapy really started as long ago as well over 100 years ago and has progressed slowly with little insights, they regarded this as of no particular significance. Indeed, they thought it was a paradox of confined to mice. And it took another 11 years before they were pushed by people like me to say this is really ridiculous. You're just looking at the cancer cell type. It's much bigger. It's the stroma and it's the immune system. And it took them quite a while before they realized there were other things, that immune responses were important and that cancers would stop this immune destruction and that inflammation promoted tumors. And to go back to what Mark's just shown you, that it was coined by Steinberg that there were 3 E's. We can eliminate cancers. It's the equilibrium we must contain. Only the immune system can do that. And if it doesn't, you get escape. What is interesting is that all this work has done is shown that you need cells other than CD4, CD8s, which are the well-known ones. You need these more basic ones, NK and gamma deltas, and these are what we've been working on. They're not adaptive, they're innate, they're there, they just sense. They can't tell one antigen from another, but they can tell danger, and it's a danger signal. And the other thing we learned from the NCI is that cancer progresses randomly. You need a mutation in an oncogene, a mutation in a suppressor gene, and you need a minimum of 6 mutations in a row before a cancer comes out. In fact, some cancers, it's more like 60, but this all takes time. And what our work started to show was that cancers arose in areas that essentially had chronic inflammation. And what inflammation does, the first thing, it suppresses the immune response and it provides lots of fuel, which allow new cells to grow, allows the cancer to grow. And this gave us an insight into what we needed to do with regards to immunotherapy and treatment. This is terribly, terribly simple. It was basically an understanding that the immune system that controlled cancer was really divided into two, what they call cell-mediated Th1 and humoral-mediated. Tim Mossman picked this up in mice, and it seems to apply to humans. And what it was found was that if you have a chronic infection, this is why infection and cancer have so much in common, HIV and TB suppress the cell-mediated system, and in consequence you get an overcompensation by the Th2. Now what we showed, I'm not showing you all the data, is that in colorectal cancer we would get this picture, and when we removed the tumour, or the surgeons removed the tumour, this would bounce back and it would go into an equilibrium. But if you can't remove it, we have to do it another way, and this is what I'm going to try and show. This is the Lorenz attractor, which basically is something, if you perturbate it, it will always come back into the same way. A bit like the seesaw, you know, when things get out of things, you want to get it back to the same place. If you want to see this in action, there's a great big one hanging from the ceiling that shows the light like that from the Science Museum. And if you kick it, it will go all over the place, but it will always come back to that. And that's what I believe the immune system does. Now, you've heard about ipilimumab, and you've heard how it affects the T cell, allows it to increase, and you've heard that it can work in conjunction with the PD-1 inhibitors. One works the lymph nodes, the other on the tumour, and that there are numerous ones of these. We're talking about these two. There are hundreds of possibilities in the clinic, and when you combine them, there's over 300 possibilities. But the problem is, and this is where we come in, the response rate to single checkpoint inhibitors is 20 to 40%. The best combinations are at just over 50%, you've heard, but they're very toxic. We need an ideal combination that's not toxic, and we wanted to research how we could get this to be better. How can you define the response? Well, what's interesting, if your tumour's inflamed and you get lots of T cells and these other cells, you'll get a response. If they can't get in, you'll get progression. But it's not always that simple. They can be invaded with T cells and macrophages that are recruited by the tumour to suppress the body's immune response. And this adds another thing to it. Now, research to date, one of the things we could never have done without the ICVI backing was to go back and look at stored serum from studies that we've had with vaccines, those who responded, who are not the majority, and those who don't respond, the majority. And we were able to show that those who did not respond well had high inflammatory markers. There was no 1 or 2. It was a signature. And this is incredibly important because this was associated with immune suppression. The other things that we were able to discover, and very much in collaboration with others, that responders have activated dendritic cells, and these cells, which are innate immune response, these are the really ones that sense this. So our work on this is we identified that there was a basic non-specific heat kill bug called Mycobacteria vaccae, developed for TB by Stanford and Rook, that increased the cell-mediated DC and NK response that was suppressed in cancers. We did a number of studies on this and showed that they work in trials both in melanoma and pancreatic cancer. And as Donald Howie has pointed out, this was the prototype for what is IMM 101. And when we put it in the clinic, you can see here alone, just alone, we were able to completely eliminate metastases in the lung. And when we combined it with gemcitabine, again, basic research we've done in the laboratory, gemcitabine was a standard drug for pancreatic cancer. We did a randomized study, standard treatment versus the combination. And look at that increase in survival. That's one of the best increases in survival in pancreatic known to date. But look, the response rate starts really early. Classic vaccines tend to start late. So with the non-responders, will they respond to vaccines and checkpoint inhibitors when primed with anti-inflammatory drugs? The answer is yes. We have that because one of the things that IMM 101 is, in addition to being stimulating the Th1, it's anti-inflammatory and damps down those side effects. And the other thing is one of the best drugs that we've worked on looking at its ability to treat autoimmune disease was thalidomide. And we went on with a couple of Brits who worked in America with a company that's now known as Celgene and made these analogues, lenalidomide and pomalidomide. And these drugs, we were just looking as how they could improve the immune response. And I won't go into all the things they could do, but this is one of the first trials that were done, showed the time to progression in multiple myeloma. It made a fantastic difference. Again, very low toxicity. And this is now the first-line treatment for multiple myeloma, which is a terrible disease of the bone marrow. And when I was a junior doctor, you'd be lucky to live more than 18 months with it. Since this drug was introduced, it's taken the average survival from 2 to 7 years, which is one of the biggest impacts on any cancer at all. Our work has shown that it has many other things, inhibits the regulatory things that suppress the good immune response to cancer, and boosts all sorts of other types. We did some very interesting work to show it enhances antibody responses, and that it would make the antibody for lymphoma work even better. It does. It's been approved by the FDA. This drug system has shown that you can get something new, old drugs for new tricks, repurposing. I mean, the drug from this, lenalidomide, 2 years ago was the largest selling drug in the world. I'm very embarrassed with that. It means that they charge far too much for it. But we are working on many others. Metformin for diabetes has fantastic anti-cancer activity. It inhibits glucose uptake and also various pathways of stem cell. Aspirin, anti-inflammatory. Doxycycline, antibiotics, also anti-inflammatory. Artesunate, mebendazole. These are used for infectious diseases but have very interesting anti-cancer activity. More recently, we've worked on low-dose naltrexone. I don't have time to tell you all our exciting things we found about that. And we did a science thing last year on the cannabinoids. So the future, I believe, from all this basic research, is before the checkpoint inhibitors, you want to prime the immune system with anti-inflammatories, boost the cell and innate immune responses with vaccines and immune modulators, and then combine with chemotherapy, radiotherapy. Well, that's exactly what we're doing with the trial, IMM 101 plus the checkpoints. It is the priming that allows the systemic inflammation to be suppressed, the inflammation in the tumour to increase, so it will respond to the checkpoints. And then the combinations with chemotherapy, we've shown that with pancreatic cancer, and we've seen it many times with radiotherapy. This is difficult to show, but I just wanted to show this patient, which is why we have the trial. He was a patient with IMM on 101 who responded for several months, and this is what was important. He had disease we could actually see as well as on the CT scan, and we put him on the checkpoint inhibitor. I think it was pembrolizumab at the time, and normally when you put people on this drug, you basically treat them every 3 weeks, and after about 6 courses you do a CT scan to see if there's been any response, and in over half the cases there isn't. And in those that do respond, there's a tiny little response, but it takes ages. This guy was on IMM 101. When he started responding, we put him on the first course of treatment. When he came back for the second course of treatment, I said, "How is it going?" He said they all started disappearing within 4 days. So this time it's an anecdotal case, but it shows he was primed. That's why he responded. And also, this has tremendous implications for the checkpoints we tend to treat ad nauseam for every 2 years. His disease all disappeared and he was able to come off. And that's something we're going to see. This is something you cannot see the detail on, but to my amazement, I've just had it in a patient with pancreatic cancer, which is notorious, does not respond to checkpoints. There's absolutely nobody has found anything. Here was a patient, he'd gone through all the chemotherapy. This is his tumour markers showing. I don't have his scans to show, they're elsewhere, but his markers were there. He put him on IMM 101. He started to respond, but then his local person put him on checkpoints. He had a total response, metastatic in the liver, and he was still disease-free 2 years later. So achieved with ICVI funding. I think we've got a vaccine program revealing the importance of dealing with background inflammation. That MVACI is the best vaccine that we tested. We did over 12 different vaccine trials, all high-tech peptide, gene therapy, oncovirus, nothing compared with this simple heat-killed bug, basically. And it enhances the response to CPIs and chemotherapy. And that repurposed drugs are the best of, are the basis of excellent new drugs like the thalidomide program. Just before I finish, just want to mention the other thing. We do very, very simple things too. We noticed that 85% of all our patients had low vitamin D3 levels. We had a third which were in the bucket in the rickets class. And so the obvious thing was to replace them and bring them into normal. And everybody said there's no evidence. At any rate, we didn't bother about that. We supplemented everybody. And I think that's one of the reasons they respond to the immunotherapy so much better. I presented at several studies, and one of the guys basically said, I've looked at my pancreatic patients treated with chemo, and you're absolutely right. Only the ones that respond have normal vitamin Ds. We've got to do it. And the reason I put this up is something that we've been saying for years, ignored, and now at ASCO this year, they published a meta-analysis showing that the lower your vitamin D3 level is at diagnosis, the worse you do unless you correct it. And if you correct it, you get a 13% increase in overall survival, whatever other treatment you're given. Put that in context, tamoxifen became a worldwide anti-cancer star on 8%. So vitamin D3 is nearly twice as effective as tamoxifen, you could say. Now, my talk is on new therapies. I don't have time for them. But you've read about CAR T cells. Today, there's antisense. Last week, there was Achilles heel attackers. These are all incredible drugs which will work much better when we do all the other things to reset the immune system and having a great effect. Now, just get to the reality. 1 in 2 people will get cancer. The average in a lifetime, that is. They've always said when I started this job, it was 1 in 5, and I thought it's 1 in 3. Now it's officially 1 in 3, but it is that fact 1 in 2. This is the bit that I think has to be addressed. The average cost of new cancer agents is £3,000 to £5,000 a month. Checkpoint inhibitors are about 100 grand a year, and we know that 2 are better than 1. CAR T-cell therapy has just been approved at £500,000 a time. Now, I'd like to know how anybody can afford that. The future is now much brighter than a decade ago. Activity has been reported in at least 23 different cancers for immunotherapies, alone or singly, in cancers other than melanoma. And for years I was told immunotherapy would only work in some melanomas. However, the current scenario of free funding and the current drug prices is clearly unachievable. So it's my last slide, and I want to acknowledge, I could acknowledge all the lab, everybody who's worked here, and that's been done already. I'd like to acknowledge the patients and all those who supported us through the CVI and now through the ICVI over 20 years, which we could not have made a difference. One of my first grants to the CRUK when I came here was turned down with our experts have shown there is no evidence that tumour immunotherapy will ever be able to be applied to human therapy. It is a curiosity confined to mice. That was over 25 years ago. And how difficult it was when we showed that inflammation caused immune suppression in cancer, and we submitted our manuscript to journals. It was turned down by 4 major journals, and each one had a referee say, this data is so potentially important that if it was true, it would have been discovered already, presumably by somebody with more insight than myself. So I wanted to just convey the difficulty of trying to change a paradigm, because it was all chemo, 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 chemo when we started. And this, I believe, and that's the bottom line, will go on to provide effective non-toxic treatment at affordable prices. Thank you very much.
Well, thank you, Gus, for that whirlwind talk for immunotherapy over the last...
I just wondered, where is this difference in sort of background inflammation coming from with your different patients? Is it age-related, or is it disease type related, or is there some other cause for why some people have higher inflammation than others?
Essentially, all disease, it's becoming very clear now that all diseases, particularly of the Western world, are due to excess inflammation. You're overreacting. For instance, and that goes with the cancers, you know, that smoking gives you inflammation of the bronchi, and that leads to 2-3 decades before the cancer arises. And there's some very interesting mouse models where they use these mice to get lung cancer to test new treatments, and if they knock out an inflammatory gene, the mice will never ever develop lung cancer. I mean, it's the same with colon cancer is clearly due to inflammatory foods, and we see every day the effect of processed foods, of hamburgers, sausages, and God knows what else, drives a bigger inflammation in the colon. And we know that if you have colon cancer, you're likely to be preceded by other inflammatory colitis or polyps, adenomas, their inflammation. Now, that sort of lifestyle goes with inflammatory markers that affect your heart and everything else. And then people get degenerative disease of the nervous system, like Parkinson's. They have these inflammatory markers. And what's exciting about the work that we've done and enabled it, because we had this proteomics facility come into the school, is that there's no one magic, and this is what people don't like. You're getting a signature. It's a signature. So I put it very simply. Say you have half a dozen markers are elevated 2 or 3 times above normal, but it's out of, say, 22 common possible ones. So there's no, everyone loves simplicity. There's no such thing. So that's basically what we mean by the chronic inflammation. It goes hand in hand, though, that when it's systemically, it seems to suppress the immune response that would normally jump into the tumour and attack it. So if you suppress the background immune response, it unleashes the normal immune response to go and attack the tumour. The big thing is, why don't these checkpoint inhibitors do it? Now, it looks like they will only do it if there's been a signal 1 that's primed the tumour. And that's become very, very clear, and that's been proven with colleagues have shown that. In the big checkpoint Pembro trial, after we presented our data at various meetings, that they checked it and showed that exactly the same signature was seen in 60% of patients who didn't respond. So this is something that has tremendous health issues for everything. It's not just cancer, it's to avoid all forms of chronic disease. And what I've mentioned earlier on, if there is one really good marker of inflammatory disease, it's a low vitamin D level.
Talking of inflammation, so we've established that the systemic inflammation needs to be dampened and the tumor specifically, the localized region needs to be inflamed. So there's lots of evidence, especially in, for example, Parkinson's disease, that the gut microbiome initiates inflammation through alpha-synucleopathy and through the vagus nerve. Basically, there's inflammation which is triggered in the brain, and that causes degradation of the nigrostriatal pathway, whatever that is. So what about we use the gut microbiome as a target and we modulate it somehow to reduce systemic inflammation?
I think that's one for Alberto.
We are already doing it, actually. So we didn't have a chance to go through this today because it's still very much in early phase. But we do fecal transplants. There are 2 clinical studies ongoing at the moment. One is in the MD Anderson, Houston, in the US, and one is in Tel Aviv. And they are basically, we showed some preliminary data last year in October at the Society for Melanoma Research Congress, was here in UK last year, was in Manchester. And they showed that non-responders to checkpoint blockades can be switched to responders after a fecal transplant from a donor who had responded previously to checkpoint blockade. So interesting field, very, very complicated. There are also some evidences, for instance, that antibiotics prior to commence treatment with checkpoint blockade may be detrimental because they change the microbiome.
Okay, ladies and gentlemen, on that point, do you want to...
Can I ask?
Julie wants to answer.
Actually, I would like to know what your treatment actually is. Is it just like an injection, just like a normal vaccine?
Yeah, I have an infusion every 2 weeks.
Yes.
Novolab. But my vaccine, yes, is into the upper part of the arm. And they alternate the arm every month. So the small one, the magic one, the IMM 101, is vaccine just in the muscle there. I'm thrilled.
In the skin.
We have time for one more
In the
question.
skin.
In the skin.
Yeah, one more question.
So I was just wondering, because a lot of the things you referenced have been
secondary cancers. And obviously, with radiotherapy being such a obviously, you get a localized inflammatory response whenever a primary cancer is treated by radiotherapy. And for instance, gemcitabine is a radiosensitizer. So sometimes whenever, because I'm a therapy radiographer, we have patients that come back because they have what are called recall reactions. So if you are treating a disease with immunotherapy and they're having an inflammatory reaction in the primary site because they're also on a radiosensitizer, will that affect the treatment that they're having? Does that make sense?
Well, it's a difficult question, but I think I perceive one of the questions is like gemcitabine. You say it's a radiosensitizer. It's interesting to know that gemcitabine was the gold standard for pancreatic cancer until combinations and FOLFIRINOX came along. But in the average patient, it's still pretty much of a gold standard. It is a useless cytotoxic, and yet it's the only treatment that's likely to make a difference 6 months down the line, both with the quality of life. And I've maintained for ages that I've researched who came across gemcitabine and found that it was actually developed as an anti-arthritic agent, but abandoned because it could only be given intravenously. So it is actually an anti-inflammatory, and what it does is switch off those inflammatory cells that surround the tumour that stop an attacking T cell from doing anything at all. And certainly in pancreatic cancer, that is the problem. They do have good immune responses, but because they've had a long time to evolve, the cancers have this shield around. And gemcitabine, that kills the shield. Does very little to the tumour. And so that's a very good precedent and sort of anecdote that giving a very powerful anti-inflammatory is enough to improve the natural immune response. Obviously, combining it with the 101, we got fantastic survival advantage. And I am still trying to get them to get the drug approved on that, because it's a randomised study, but under the way they license drugs at the moment, they want 2 randomised studies. Well, that's going to take years and millions of pounds, and I don't think it's necessary, because the regulatory people, they need to make sure things are safe. And we have hundreds, if not thousands of years of drug years of safety with this agent. And giving it the gemcitabine is one of the several drugs that I think is a logical thing to do across different tumour types. Does that answer your question?
Yeah, I was just kind of wondering, because as you said, like a local inflammatory response elsewhere can cause problems with the immune response.
Could I interrupt?
Sorry.
We're going to have a bit of time. You can come and speak to Gus actually afterwards, perhaps. And,
So Julian's going to wrap up now. So Gus and Alberto, Mr. Howie and Marie and I will stay around after wrapping up, and please feel free to come and talk to us with any questions you might have. But thanks for your attention.
so thank you. Well, yes. Well, you preempted me. I was going to say thank you very much to the speakers for a fascinating evening. I think, as pointed out, really nice to have so many different perspectives around